So you alluded to a problem that we're all going to have as we develop newer therapies that we're using up front, and that is what to do with the patients who do relapse or have refractory disease. Right. So how are you starting to think about how to approach those patients now that you have patients who may have been on immunochemotherapy long before these drugs, or BTK inhibitors, and now venetoclax? How are you going to, what kind of factors go into deciding how to treat them next?
So I think one of the really interesting things that's coming along is this idea that we're going to get patients into a remission, for example, with ven plus oben as their frontline therapy, and then let's say 3 or 4 years later the disease comes back. What do we treat them with then? So I think my preferred choice would be ven plus oben again, because they responded once before. Hopefully they will respond again. We don't know that yet. We need to show that. But trying to use drugs of the mechanism that have been working for as long as we can before switching to a different mechanism and saving the next mechanism for when they become refractory to the initial mechanism. And we may find down the road that we can just treat patients with a year of ven plus oben once every 4 or 5 years, and they never become resistant and they do well for the rest of their lives. So that's one scenario. Or we may find that the second time we treat them, they don't respond, or they respond much less durably, and so then we need to be more proactive about switching mechanism. So that's sort of how I think about that aspect of it. You know, you're going to have patients who go through multiple lines of therapy, as you described, and I think that is where the CAR T data start to become very exciting. I've personally had some patients who've been in that scenario where they've been through chemo immunotherapy and BTK inhibitors and venetoclax and respond to CAR T therapy and can have durable responses. So it's certainly very promising.
So you're not mentioning using immunochemotherapy in the relapse refractory setting. Is that dead?
I would say that's pretty much dead.
Really?
Yeah.
Wow.
Yeah. So
pretty confident there.
Yeah. I think that the challenge with chemo immunotherapy in the relapse refractory setting is that, number one, the durability of the benefit is clearly going to be less than it was in the frontline setting. Number two, you're going to engender more clonal evolution, enriching for deletion 17p, TP53, and making these patients much more resistant even to the novel agent-based therapies you may want to use later. So I do hear this question commonly from some of my referring doctors of, this patient responded to BR for 5 or 6 years, so I'll just give BR again. I might only get 3 or 4 years out of it. That would be good. It would be good until they develop clonal evolution of the CLL, or even worse, they have to visit you for a myeloid neoplasia. And so, there's a number of factors there, but I think now we have enough data suggesting that we should be using novel agents exclusively in the relapsed refractory setting whenever we have access to those drugs.
Okay, well, I definitely agree with your point about using a regimen that's working, a mechanism of action that works, if you get a good first duration of response, to definitely try it again. Don't abandon things that are working. Right. It seems, though, that you've just drawn a distinction then, though, between immunochemotherapy because of clonal selection and other myeloid disorders and these new targeted therapies in that kind of approach.
That's a great point, and I think that's why we're all so excited about the venetoclax obinutuzumab regimen, because it's the best of both worlds. It's novel agent only, and it's time limited. Yeah. Before we had to choose. We could either do time limited with chemo, which had all these different down the road consequences, or we could do novel agent but continuous therapy. But now we sort of have the best of both worlds with this new regimen.
How about allotransplant?
So there is still a role for allotransplant in CLL. It's certainly decreased over the years recently. But we still think about it for patients who have deletion 17p or TP53 mutation, who get into a remission. When they get into remission with, say, ibrutinib in their frontline setting, it's something I always talk about with them if they're young and otherwise fit. Not necessarily that they need it as their next therapy. But we know that venetoclax only has about a 67% response rate or so for those patients who progress on ibrutinib. And so I think it's something we need to mention to our younger fit patients. I'm hopeful that as CAR T develops, it'll start to take over that place of allotransplant, but we still do have a 40% long-term progression-free survival rate with allotransplant in CLL. So it's something
and CAR T cells not yet approved in CLL, right? I mean, it's still
investigational. Yeah.
Okay, but clearly important. Are there, for BCL2 inhibition, do you check BCL2 levels or Bh3 expression? Is there any biomarker, or the response rates are so high it doesn't matter?
So there's no specific biomarker right now in CLL. The levels of protein of BCL2 are uniformly high in CLL patients. And we do a technique at Dana-Farber called Bh3 Profiling, which actually looks at the functional levels of the different proteins and how they interact with each other. And that's investigational. It's something we're looking into, seeing if it could be a biomarker. But so you have to look down the road at how well this predicts the durability of response, because most of the patients are going to respond initially. So it's been a little challenging to develop a biomarker in this space, and it's not going to be a simple measure like BCL2 expression or something like that.
So we've talked a lot about, how you choose the next line. Tell us a little bit about the data and your experience using venetoclax in that relapsed refractory population.
So the venetoclax experience started with monotherapy in the relapsed refractory population, where the overall response rates were around 80% and complete remissions in the range of about 20%. But certainly the addition of rituximab seems to have benefited patients, and so the Murano regimen had very deep and durable responses with only 2 years of therapy. And I think that's really the advantage of that combination with rituximab. It allows you to get to time-limited therapy. And there's some nuance as to who can stop therapy or not. The way that the regimen was designed was that everyone would get 2 years of therapy and then stop, regardless of what stage their disease was in. We did find that patients who had MRD that was detectable at the end of those 2 years tended to be the ones who were progressing. So there's some debate right now about whether certain patients may either need more than 2 years of therapy or may need to switch to a different therapy if they're not undetectable for MRD, or maybe even add an additional drug at that 2-year time frame. So there's still a lot of interesting questions, I think, around the optimal way to treat relapsed refractory CLL with venetoclax. We certainly learned a lot over the last few years in that respect.